Okay, I believe we are now live. Welcome everyone. Thanks for joining us this evening for what's going to be a great event. We've got Dr. Pippa Sangster joining us for an event all about Micro-TESE and what you need to know. And that, that's our main aim and objective here at Nexus Fertility. It's getting people good, well-sourced information, because the internet, as we know, is full of people talking perhaps out of hand sometimes. And Micro-TESEs are one of the most commonly mentioned things and asked about topics about male fertility that I see online. So literally, I couldn't think of anyone better to join us this evening. As I said, it's Dr. Pippa Sangster, and she's a consultant urologist at the University College Hospital in London and leads the male infertility service. She specialises in andrology and male factor infertility, and is also a Micro-TESE expert. So, like I said, couldn't think of anyone better to join us.
Oh, thank you.
Thank you so much for joining us. Just before I get started, Pippa, I'm just going to read a quick disclaimer that we do ahead of our webinars.
Yep.
So, Nexus events are designed to provide objective oversight, balanced information, and general guidance. Nothing shared during these sessions is intended to replace personalised medical advice. Always consult your own healthcare provider with any questions or concerns about your health, fertility treatment, or changes in your condition. So, without further ado, like I said, Pippa, welcome. Thanks for joining us.
Well, thank you for having me. I'm really pleased to be here. This is a topic I really feel very strongly about and really like to talk about. I think it's really important that patients have this information. So I'm hoping we're going to be able to cover lots tonight.
Yeah, definitely. Thank you. Like I said, I see it mentioned all the time online, and that's one thing, a problem that people are having to take to forums and Reddits, for example, to ask these questions. But what's even more concerning is that people answer. And don't get me wrong, there's a place for lived experience, absolutely. But when people then start venturing into more of the advice and guidance about the operation, and whether people should have it or not, that's what really then does start to become a bit of a problem, which is why we want to give guys this opportunity to listen to this information from yourself. So I think probably the best place to start, a good place to start, would be to just to ask the question, what is a Micro-TESE? And probably, am I even saying it right? Because I've heard it referred to a Micro-TESE, Micro-TESE. But
So I say Micro-TESE. So it comes from TESE, and that's a testicle extraction of sperm. And Micro-TESE just indicates that we are actually using a microscope during the operation. So it's an operation that's used very specifically for men who have non-obstructive azoospermia. So I know that obviously you've got a lot of men and a lot of patients who have infertility who might have sperm in their ejaculate. And it's not needed for those men. So this is for men who have no sperm in their ejaculate, so azoospermia. And a lot of these words, and I'm going to apologize now, I talk about this stuff so often, it becomes very commonplace for me, but you'll hear words the whole time and patients will come and say, oh, well, what does that mean? And so if you have the ability to ask their questions today, please, can you just ask if I say a word that you don't know or don't understand. But so Micro-TESE is a testicle sperm extraction from a man done with a microscope. And it's done as an operation. It's a general anesthetic, so you're fast asleep. Some people across the world have talked about doing it under local anesthetic. I see no reason to be awake during this procedure, which would be a bit uncomfortable, and I don't think local anesthetic would ever completely numb you. Although I know people will always try and do things just trying to minimize cost. But the way I do this operation is it's a general anesthetic, and it's a day case, so men will come in and go home the same day. It takes anything from an hour to 2 hours, depending on how tricky the procedure is and how long it takes to find sperm, if we can find sperm.
and I've just put it in the text box actually to say, encouraging people, if there are any questions, this is an amazing opportunity to ask them. So how does the Micro-TESE compare to other sperm retrieval techniques such as a TESE or a TESA? Again, I'm going to apologize if I pronounce anything wrong.
You're not saying anything wrong. So why don't we go through all those sort of abbreviations, because there's a lot of things out there that patients will hear and men will hear, and you think, right, well, what's the right one for me? So they're all different types of sperm retrieval. And the first one, the least invasive, is something called a TESA. And a PESA, so PESA, is a percutaneous epididymal sperm extraction. And all that means is there is no cut on the outside of the scrotum. And it's just a needle that we use to put into the top of the epididymis. Now, I should have brought a diagram actually today, so I'm just going to just really quickly explain. So if you think about your testicle, I don't mean your testicle, Sean, I mean the greater testicle, but if men's testicles, so you have the round testicle, and on the back of the testicle is the tube that comes off the top of the testicle, and that's called the epididymis. And if you were to be fiddling now, you would feel your testicle and feel a lumpy thing towards the back of the testicle. And that's the epididymis. And so the PESA is where we put the needle into the top of the epididymis. Now, that is only for men who have a really big obstruction of their testicle. So actually in situations where someone might have had a vasectomy, so where we tie off the two vas, so testicle, epididymis, and then it goes into the vas. So when you hear men are saying they have a vasectomy, we've just tied off those two tubes. And then what happens is that obviously the testicle carries on making sperm the whole time, and the epididymis gets big and swollen, and it's really easy to pop a needle into the top of that epididymis and take sperm out. But that is not for men who have non-obstructive azoospermia. And when I hear that men have had attempted PESAs, when we know they have symptoms and signs of non-obstructive azoospermia, it makes me really upset, because that is the wrong operation. And although everyone always wants to go through the least invasive, actually what you want to do is go through the most successful. So PESA is not appropriate for non-obstructive azoospermia. The next one is a TESA, and that's an aspiration of the testicle. And again, that means no cut anywhere. It's just a needle or a big syringe goes into the testicle, and inside the testicle, if you imagine it's like millions and millions of balls of wool or string. So that's what is inside the testicle. And so what the needle is trying to do is to grab one of the strings and pull it out. And again, that is for obstructive azoospermia. If you wanted to have a successful procedure, it's not for someone who has non-obstructive azoospermia. The next one is a TESE, so TESE, and that's just a biopsy. So in that situation, there is a cut on the front of the scrotum. We pull the testicle to the front of that cut, and then we can make a small biopsy on the testicle to get sperm, versus the Micro-TESE, which is actually where the testicle again is brought to the surface. And you know, I never know how much information men want to know about this, and some men are very different, and some men will come and say, "Oh, I watched the video on the Micro-TESE," and I'm like, "Oh, wow, I don't know why you would do that." And other men, really want to know as much as possible, and some men don't want to know. So the Micro-TESE always sounds a little bit. It sounds quite vicious, and so I'm always a little bit reluctant to describe it completely. But by using the microscope and by bringing the testicle to the surface, I can actually open the testicle, and then I can see all of the tubes. And the hope is that if we look with the microscope and we look at the tubes, you can see more healthy tubes. So, doing a Micro-TESE, you can see like lots of really poor looking tubules, thin, scrappy. I know I'm not likely to find sperm. And then you'll see these clumps of thick, white, fatter, healthier tubules. And we can pick those out one by one. And actually, it's much less traumatic to the testicle. I can be really careful making sure I'm not hitting any blood vessels. If there is any bleeding, I can deal with it there and then. I personally feel that actually it's a really good operation, as opposed to the blind stabbing of testicles where I can't see what's going on underneath the scrotal skin. So although a lot of people say, oh, it's a lot more invasive, I feel that it's a lot safer and it causes a lot less damage than some of the other procedures. That was a really long answer, sorry.
No, it's really interesting. It's quite incredible. Like medical science always blows my mind. I don't want to put you on spot, but how was that even discovered? Do you know?
So testicle biopsy, people have known about doing things like that for 20, 30 years. In terms of using microscopes in medicine and surgery, again, has been used for a long period of time. When you're looking at tiny tubules in the testicle, and then sperm in the testicle that we actually can't see with the naked eye. So, you can't see sperm. You have to use a microscope. It's just evolved from that. And then once they started doing the Micro-TESE and seeing that actually in men with non-obstructive azoospermia, it was increasing our chance of success. It was decreasing the damage we did to the testicle, decreasing risks of bleeding, hematoma, and other kind of complications that we'll go through. It's just evolved since that, but it's a very specialized procedure, and so it's not something that everyone does. And whereas, we've discussed this before, male infertility, for so many years, men were looked after by the gynecologists that were doing the IVF. So gynecologists are trained to treat and look after women. They're not trained to treat and look after men. They're not trained to operate on men and the testicles and all the risks and problems that go with it. So, one of the good things I also think about Micro-TESE is the people who can do Micro-TESE are real experts. They really know what they're doing with your testicles. And I think it's very important that men are operated on by urologists who know how testicles work, know how we get around them. We really are trying to move away from the days of where gynecologists were operating on men.
Yeah, definitely. And yeah, I can attest to the fact that it's definitely something that you want to go under general for. Having had one myself, I couldn't think of anything worse, to be honest, than hearing what was going on. How long does the procedure take?
So in general, you'll obviously come in, you have the anesthetic, and the anesthetic can take 15 or 20 minutes. The operation, it depends whether we find sperm and how quickly we find sperm. So from my point of view, if I am doing a Micro-TESE, I would only ever do a Micro-TESE if I have the embryologist in the room. So when we're doing the procedure, there's a few important people in that room. The most important person is obviously the patient. The second most important person is not me, it's the embryologist. So when we're operating, I am giving little tubules to the embryologists who are sitting there separately away from me with a different type of microscope, and they're emptying out the tubule saying, yes, I've seen sperm, or no, I haven't seen sperm. And by having that embryologist in the room, it means I can really minimize the amount of trauma or damage we do to the testicle. So some people will do this operation without an embryologist, which, it's fine in terms of you do what you have the availability to get to. But the embryologist sitting in the room means I know very quickly if we're finding sperm. And so if we're finding sperm, it might mean that they and I will have a discussion, and very quickly we'll realize we have more than enough sperm for multiple cycles of IVF, and I don't need to go to the second testicle. Whereas if I didn't have an embryologist, I would have to do the Micro-TESE on both testicles. So from my point of view, when I do the operation, there's a couple of things I want to do. Obviously, number one is find sperm. I secondly want to make sure that the patients never have to meet me again. And that's not because I'm not delightful, but, it's in the NHS, it's a painful, long trawl to get to see someone like me, get on the waiting list and do the operation. And if it's in the private sector, it's a really expensive thing. So I want to make sure you never need to see me again. So I want to find enough sperm for multiple cycles of IVF. So the embryologist and I are talking the whole way through the procedure. So if they find sperm, super, but how much sperm have they found? Have you got enough for 5 or 6 vials? And I'll very quickly explain what that means. So after you have your Micro-TESE and the embryologist are looking through the tissue, they will divide it into vials of sperm. And that doesn't mean that one vial has one sperm, but what it should mean, if it's a good embryologist, is each vial is enough for your average IVF cycle. So say you had a youngish partner who was going to have 20 eggs retrieved. I mean, wouldn't that be fabulous in all cases? We know it's not always like that, but what I want to have in that vial is enough good quality sperm to fertilize all those 20 eggs. And so the embryologist and I are talking, they're saying, yeah, I've got some sperm, but either the morphology is not great, and by morphology, I mean, what does it look like? They might say it doesn't look brilliant, or doesn't look healthy, or there's a problem. When you talk about motility, so it's not like when men ejaculate and you have a semen analysis and they talk about motile sperm. Testicle sperm is not normally motile. So when we're doing the operation, I'm not expecting them to say it's motile when we're getting testicle. They have to take it back to the lab. We add a chemical to it and we see that it's motile and usable at that point. So embryologist and I are chatting. No. If they keep saying no, and I'm going all the way through the testicle, then I will go to the second testicle. And then I'll often say to men, look, even if we don't find sperm during the operation, that doesn't mean there isn't sperm. The embryologist then take the tissue away. We have much better equipment off-site where they can spin tissue down. The chance of finding sperm back in the lab is much higher than in the theatre, but it just gives me a really good indication.
And in terms of that secondary analysis that can take place in the lab, if there's not a lab on site, what could that waiting period be for men?
Well, I'm trying to think about the different departments that do this across the UK, and some of them will have to, I mean, obviously the tissue has to get analysed that day, so you should know that day, because they'll go through the tissue that day and they'll break it up into different amounts of sperm, but you might get your phone call the second day. In terms of our lab at UCH, you know, our embryology team are phenomenal, and we work really hard to make sure that, you know, obviously our operation's always first thing in the morning. We work really hard to make sure that men are having that phone call by about 4:30 in the afternoon, 5 o'clock. So from my point of view, you should know on the day.
And is it possible that someone would know immediately after the operation, like if there was literally nothing, no viable tissue?
Not, definitely not, because they have to be able to, I have to get the embryologist to take away and look at it properly. You know, when you've done as many of these operations as I've done, and I'm sure I've done more than a lot of people in the country, you know, when you're doing thousands of these, you get to know what different testicles look like, what different testicle tissue looks like. And when the embryologist and I are going through the procedure and they're saying no, and I'm looking at the testicle, I can often have quite a good idea. And so, you know, it's a difficult thing to call until the embryologists have given the final answer, but I will have a hunch after the operation. And so I will often say to men, look, we haven't found sperm. I'm not feeling overly hopeful, but let's see, because I get pleasant surprises every day. I love being proved wrong.
Yeah, that's good to know. Thank you. And something that you'll be acutely aware of is that when you're seeing patients who are struggling to conceive, often people are trying to cling on to any hope they can get, and that hope can often translate into percentages and outcome rates, like kind of fertility rates, you know, live birth rates in the clinic. But when it comes to Micro-TESE, is there a generic percentage, firstly, for viable sperm that have been found, and then secondly, how does that translate into live birth rates?
I mean, honestly, the answer to that is no. But I will go into a lot more detail than that. But it is so different why different men are coming to see us and the cause of the non-obstructive azoospermia. So that will change the success rate. So there might be a genetic reason. So you might have something like a micro-deletion, and I'm not sure how many of your patients or your the guys on here will know about micro-deletion, but that's a genetic reason. So on the Y chromosome, there's a small area that codes for sperm function, and that can be deleted. And so that will have a slightly smaller chance of us finding sperm. If you have something like Klinefelter's, which is where men will have an extra X chromosome, that will have a much different success rate. So in general, if I talk to a man who has no genetic abnormality and his hormones are all fine and he hasn't had trauma and there hasn't been, you know, an obvious cause, then we tend to say the success rate is about 50% of finding sperm. If it's something like Klinefelter's in the UK, the success rate is 28%. If you start talking about the microdeletions, you know, that's a little bit variable, and that can be anything from 30 to 70%, depending on the papers. And this is one of the biggest issues that we have with any kind of research where it comes to fertility, is for us to have a really good research paper, we need to be doing randomized controlled trials, and fertility patients don't tend to want to be in those randomized controlled trials. So the study rates aren't great. But so I will say to most men without a known factor, look, the chance of us finding sperm is 50%. You obviously then need to translate that into a baby. It doesn't matter whether I find sperm. What you want is a baby. And that's very different to 50%. And for that, you need to then start taking into account the woman, how old she is, her medical problems. And so then in terms of the live birth rate after a Micro-TESE with non-obstructive azoospermia, there's many studies out there which is called a meta-analysis, where they try and sift through all the good research and come up with a value, but they all have problems because it'll be a different surgeon, a different embryologist, a different cause, but they tend to say the success rate is around 29% for a live birth rate. But again, there are just so many different factors that come into that. But I think probably, Sean, where you're heading with this, and I might be wrong, is, you know, men need to know all this before they can make a decision about whether they're going to have a micro-TESE and whether they'll put themselves through this. But actually, there's not many men who I meet who probably wouldn't put themselves through it, even if the percentages were even lower, because I think there's always that feeling of going through their life thinking, well, what if I'd done this, or what if I'd done that? And so a lot of men would just say, look, I know the chance of success is really low, but actually I'm going to put myself through it because I don't want that doubt through my life. So yes, it's important to say to you, look, your chances of success of finding sperm is 50%. After that, if we find sperm, chance of having a baby is, between 20 and 30%. But I bet it wouldn't change most men's decisions if it was a lot lower. I might be wrong.
Yeah, no, you're right. And actually, that's a question that my wife asked me when I was deliberating having the operation. And she simply said, what would you regret less? Having it and knowing the potential risks and that you go through that and there's nothing, or not knowing ever and always having that as a question mark. And it was such a succinct way of clearing the air for me, because I had got in my own head around it a lot. But yeah, I appreciate your answer. And I think the key there is this is so subjective, and to sit down with your fertility doctor, your urologist, andrologist, and have that conversation. Every factor is different. Every person is different. And yeah, is that conversation is best placed between you two. But I appreciate, you're answering as best you can. Thank you. So I mentioned one of the reasons I was kind of contemplating and debating whether I had to have the operation was because of the risks. I had the leaflet, probably a lot of people get. I didn't actually go too far down a Google wormhole, which I'm pleased to admit, but just simply on the leaflet of information about the operation was enough for me. And I started to really get bogged down in the potential risks. And so if we could just discuss that a bit, what are the considerations that people should have before having what is, quite a big surgery?
So what I will warn men about when we have your operation, you obviously go through something called a consent process, and consent is where we talk about the risks. So for micro-TESE specifically, there is a risk of a scar down the middle of the scrotum. There will be a little cut, probably about 5 centimeters. The scrotum heals really nicely, so often it's quite difficult to see the scar within a couple of months. So scar is one. Bleeding is another. So any operation has a risk of bleeding. But as I said to you before, I actually think that with the micro-TESE operation, your bleeding risk is lower because I'm looking at exactly what I'm doing. With the microscope, I can cause a lot less trauma. Not only is there bleeding on the skin, but you can get bleeding inside the testicle, and there's something called a hematoma, so a little blood sort of collection in the testicle, and that can delay healing. And the risk of a hematoma is probably between 8 and 9%. We then talk about infection. We will give you antibiotics during the operation. In terms of post-operatively, you don't routinely need antibiotics afterwards, and the risk of infection within the skin and the testicle is again between 5 and 10%. And here I will say really carefully, it's really important that if men start to have increasing pain, any redness, any discharge, you need to see the doctor, and see the doctor quickly. Because that infection can get into the testicle and cause a lot of trauma if we don't get on top of it. But those are all fairly minimal risks that you would get with any operation. We then talk about the bigger risks, and the bigger risks long term. So low testosterone after the operation. And I'm talking about men who are coming into this procedure with a normal testosterone. We have seen that actually when we've looked really closely at our patients, the chance of a low testosterone after the operation, if they have a bilateral, so left and right side of micro-TESE, is 3%. So it's not huge, but it's something that we need to be aware of. And again, this is why all men who've had a micro-TESE should have a testosterone check at 8 weeks after the operation. And we keep a really close eye on anyone whose testosterone is a little bit low. If it is low, I will boost it up with some testosterone gel for a period of time. And then chronic testicle pain. And I would say, that's the bad one, because, the operation, obviously the day is pretty miserable, but what you don't want for the rest of your life is painful testicles. And actually any operation on the testicle, anything, so vasectomy, removing a little cyst, anything has a risk of pain in the testicle, because testicles are fairly sensitive and they have what I call memory. They don't like being touched. And so the risk of having chronic testicle pain after the operation is between 5 and 8%. So those are the main risks. Those are the things that I warn patients about. And then in addition to things like not finding sperm, obviously being the biggest concern for a lot of men.
Yeah, of course. And I was about to say I think, but I'm pretty sure I know the answer to this question is another subjective one, but I think it's worth asking anyway. But when we talk about recovery times, because I know what mine was, and I know, having spoken to other guys, that theirs was half that, for example. But is there anything that can impact that other than the kind of general subjectivity of how we heal in ourselves anyway?
The most amazing thing is if we find sperm, men recover so quickly. And so it just shows you how important your brain and your psychology are in terms of healing. So I know when we don't find sperm, the recovery is going to be worse in terms of pain and how they get over it. But I can't tell you why. For some men, they will say, oh, I was fine the next day. That's not true for majority of men, but I definitely hear quite frequently, oh, I was fine the next day. The majority of men will be sore for 2 weeks. So I think you feel like you've been kicked in the balls by a horse for the first week. I'm definitely not popular for the first week. You have that kind of funny walk that we talked about, the cowboy walk. And then after the first week, that should start settling down quite quickly. By 2 weeks, starting to feel back to normal. But I wouldn't be expecting you to do any sport for, a good 4 to 6 weeks. If there is a complication such as a hematoma, a little bleed, anything like that, and that's going to set you back a bit as well. But most men, I'll say, look, take a week off work, maybe your second week if you can, try and work from home as much as you can. It's the public transport, the moving around that can cause trouble. But yeah, it's, as operations go in terms of operations an andrologist does, it's definitely not the biggest one we do, but, it can cause a lot of mental strife.
Yeah, and I really love that you've pointed that out, because it's so true. I felt that I was rock solid before I went into that I was at the point where I was not going to have it. I thought, no, I'm okay with this. I had considered using donor sperm, and that I was okay with that. And despite all of that, and despite thinking that I was at a point of acceptance, having that answer, that final door closed, it took me back, and it did take quite a few more months actually to then progress after. And again, everyone's different in that respect, but I was really thought I was rock solid in that. But there's something about that, having that door closed forever, that does take that bit of time mentally to heal.
Yeah.
And what I'd say to any guys is just really lean into your partner at that point, because you'll need her, not just for the obvious, like helping you get around or get a drink or something, but it's really comes down to that partnership, that rock that you formed probably for a year or two at least, getting up to this point, navigating systems, etc. So yeah, it's talk if you can. You've got our support group, etc. It's do not underestimate that. And like I said, I'm really glad you pulled that up. So thank you. So yeah, we've got some questions, which is great. I guess I just want to ask if there's any final considerations and advice that you give anyone who's thinking they've got it coming up, or that it's a potential for them.
So other things that I think are really important about this operation is I want men who have had the operation where we failed to find sperm to be able to close the door. And that's really important. And so I'll say to almost every man on the day of his operation, today is a good day, whether I find sperm or not, because it gives you the ability to move forward. Things that stop people moving forward are they have this operation in not the perfect situation. And so I don't want to do this operation on any man unless, in my medical point of view, he is perfect. And so by that, I mean that his hormones have been checked, tested, and if he has a low testosterone, that I've pushed it up to normal. If he has a big varicocele, that needs to be treated. There's a number of different medical things that I need to go through to make sure a man is perfect, because what will happen if you have a Micro-TESE and one of those things has not been sorted out, you will continue with the doubt. Do you think we should do it again? Do you think we should now treat the varicocele and then do it again? Do you think maybe we should have some hormone stimulations and then do it again? And so from my point of view, I'm so strict on this. You don't get this operation until you are perfect. And I think if you see someone who is not dealing with this sort of stuff the whole time, you will be in that situation. So make sure you are seeing someone who you feel has fully investigated you and investigated and treated everything else. So it's important to talk about hormones, and it's important to talk about varicocele. But Sean, I'm not sure if you want to do that tonight or another time.
Oh, it's a topic that we really want to cover, varicocele. So yeah, it's vital. But sorry.
So, from varicocele obviously being an incredibly important reason that men have problems with their fertility, less so causing azoospermia and more sort of problems with sperm counts. But actually, there are many men who, we examine them, they've got huge varicoceles, no sperm in the ejaculate. Now, we've looked really closely at this data at UCH. I'm hysterical about varicoceles, examining men, getting ultrasounds and treating them. And in our data at UCH, we've seen that if men have azoospermia and I treat the varicocele before the Micro-TESE, 12% of those men get sperm in the ejaculate and don't need the Micro-TESE. In terms of does it improve the chance of success of the Micro-TESE, I don't have those numbers and the data yet. In terms of, I do so much to men before their operation, in terms of I will stimulate them with hormones, I'll do their varicoceles, I'll do their life, we do everything, because this is your one chance. You don't want me to say, I'm just going to fix the one thing. And then we don't know what's really made the change. So we throw everything at you to make you as perfect as you can. So it's always difficult to pick it out completely. And this, again, is one of the problems with the research when it comes to fertility. But I'm a very strong believer in, if you have a significant varicocele, you should have that treated before your Micro-TESE, if you have time. And by time, I mean, how old is your partner? And this is one of the biggest issues in terms of NHS and funding, is it often feels like couples have been walking through mud to get to someone like me. And then you meet me and I say, now I'm going to delay you by doing all these other bits and pieces. I'm often not popular, but you want to mentally know that when you have that Micro-TESE, that everything else has been sorted out perfectly.
Yeah, definitely. I think on the topic of varicoceles, specifically with azoospermic patients, there was a study at the UCH, wasn't there, a few years ago around that?
Yeah, published. We haven't. We're writing up and publishing our data at the moment about the up-to-date data, which is really, really exciting, and very, very important to say that if you have a varicocele, it should be treated before your Micro-TESE.
Yeah, I watched a talk on it at Fertility 25 back in January, and
Okay.
I would advise anyone that when the study is published, you don't have to be medically minded to read it. It just helps close doors as well. It helps understand, because often when you're going through these things, you're in a state of trauma, stress, and it's hard to really rationalize a lot of things. So, and obviously you do such a great job in doing that at the time, but it's great in hindsight sometimes to go back and put the puzzle pieces together as to why things happen. Because I had that through yourself. I had that varicocele embolization prior to a Micro-TESE, and I was azoospermic. So it just helps join the dots.
Yeah, absolutely. And I suppose maybe, Sean, it's something we should be saying is, when men are seeing the urologist, things that I think are really important for your men to be asking for is, everyone must have early morning hormones. Everyone. You've got to have testosterone, FSH, and LH checked. Everyone should be examined by a urologist, lying and standing. If you have azoospermia, everyone should have an ultrasound of their testicle. And when you have that ultrasound, it is so specific about, I can't tell you how important it is to have a good ultrasound. And there are so many bad ultrasounds. And so ways that you can work out whether you're having a good ultrasound or not is, obviously the person fills you with confidence, but the gel they put on your scrotum when you're having your ultrasound should be warm. You should be scanned lying and standing. You need to know the diameter of the varicocele, of the vein. You need to know if there's reflux. We should probably point out the caveat here. My husband is a uroradiologist. And so we are both obsessive about varicoceles and scanning testicles. He knows how hysterical I am about ultrasounds and how cross I get when they're bad. And so we've worked really hard in terms of looking at the ultrasounds and trying to work out what makes a good ultrasound and a bad ultrasound. But you should be getting a good ultrasound. And I get a lot of reports, and I can see straight away the report is an absolute load of rubbish, and just throw it in the bin. There's no measurements of the testicle volume. It's not telling me anything about the epididymis. It's not saying anything about veins. Throw it away. It's just such a waste of time. So the ultrasound is really important, who you get scanning. And then, just the caveat of, if your testosterone is low, you shouldn't be going through a Micro-TESE. You should be making sure that you have hormonal stimulation, because you need a good intratesticular testosterone. You need the FSH, which is the hormone the brain should be stimulating. You need to be seeing someone who understands these things, who can look after you properly.
And I can confirm you absolutely do. Everything you said happened. To the letter, and I remember actually when I was first referred to you, you literally just said, "Right, I'm doing this all again." Like everything from semen analysis right through. You said, I want to run my own test." So yeah, thank you.
Well, as I said, it's so important for you and me on that day of the operation. If I don't find sperm, I've got to know I did it properly, and you, for the rest of your life, need to feel that we did it properly together. So it's vital.
Yeah, absolutely. Well, brilliant. That seems like a really good time to bring in the questions. So I've had a couple from today, and then some that were pre-submitted, which I'll come on to. So from today, what do you think of extraction procedures for high DNA fragmentation?
So so someone has sperm in their ejaculate, and then a testicle biopsy is done because they've got high DNA fragmentation. I feel very strongly that it's very important to point out that the research and the evidence available for this is very poor, and we don't have data to say that this should be happening. And it is, in my opinion, a way that people can make money, and so you need to be careful of why this might be suggested. So over the years, many years now, I have men who refer to me and they say, look, they've gone through IVF or ICSI, it's gone really badly, we can't find a cause, we don't know what to do, let's try something different, let's use testicle sperm. And actually, there is a big push from South America and from certain European countries to say that actually, well, maybe we should be thinking about doing a testicle biopsy. But actually, we've looked really closely at, there's only nine good papers where there is good methodology, good research. And when I say good, I mean 9 papers that you would classify as something that you could use. And each of those 9 papers has such big problems with their stats. I just don't feel we have the evidence to put a man through a surgical procedure. We started doing this a few years ago, and actually we looked at our rates, and the IVF outcomes were only very slightly better with the testicle sperm. And actually, the more cycles you go through, the more likely you are to fall pregnant. And so was it just that we just done another cycle? So I don't feel that we're in a place to do that yet. And I think if people are doing this, they should be doing it as a part of a research and trial. And so, no, I feel quite strongly, Sean, at this point, I don't like it.
Okay, thank you. Hopefully that's answered the question. If it was an anonymous question, which
quite strongly, I'm sorry.
Yeah, that's great. I'm really pleased that one of the things we can offer on this platform is the ability to ask questions anonymously. So, but yeah, if that person wants to follow up with anything, please do. In the meantime, I'll move on to the next one. Can a Micro-TESE affect the size of the testicles post operation?
Yeah, it can. It can. So those 3% of men who have low testosterone after the operation, it's because the testicles have been damaged, so they can get smaller. So it's not a common finding I hear from men, but I definitely hear some men will come and say, they feel a bit smaller than they were before. If you have any kind of significant complications, so a post-operative infection or a hematoma, then yes, you might notice the testicles a little bit smaller. I suppose the way to look at this is the testicle has 2 jobs, but one is quite important, which is your third. So the first is that to make sperm, and obviously with a non-obstructive azoospermia, it's not doing that job particularly well. Second is to make testosterone, and if that is damaged, it is very easy to replace your testosterone. But then the third is also cosmetic and how you feel and your body positivity. And you know, for some men, actually feeling like your testicles are shrinking is fairly miserable. And if you are started on testosterone after the operation, any kind of exogenous testosterone will shrink your testicles, and that might be a cause as well. So yes, it can. Is it a disaster? Well, from a medical point of view, no. But you know, from a male point of view and how you feel about yourself, then obviously that's important.
Thank you. Another question's just come in. Is there a higher risk of having problems with the baby due to sperm DNA quality later on when undergoing a micro-TESE?
So not when it comes to testicular sperm versus ejaculated sperm, and there is not yet enough. You know, there's been concerns for many years now. Is when you have ICSI rather than IVF, is there a very slight increase in birth defects? And the evidence again is fairly wishy-washy, and it's nothing that people are significant enough or worried enough about that they've stopped doing ICSI. But in terms of testicular versus ejaculated sperm, no, there's not that evidence.
Brilliant, thank you. And I'll go on to some of the pre-submitted ones. Are there any lifestyle changes I should consider before the procedure to improve outcomes?
Yeah, so just like we were talking about with the varicocele and all the rest of it, you want to go into it thinking you were perfect. And so, you know, I think you should be really trying to improve your diet as much as possible. So trying to minimize processed food, you really vegetables, fruit, all those things. Sean, a whole nother topic about supplements, antioxidants, vitamins drives me wild. Again, I think a real money-making business out there. If your diet is brilliant and you're eating lots of fruit and vegetables, I just do not believe there is just not enough evidence out there to prove that it's needed. There's a really great Cochrane analysis, so I point you towards that research. It's really easy to read. So Cochrane analysis into antioxidants is a very mild improvement in live birth rate, but really mild. And when you look at the data out there where people say, oh, look, I took this antioxidant and look, my sperm quality is so much better. Again, you know yourself, when you and your partner are trying for a baby, you don't just try and fix one thing, you fix everything. You try and keep your testicles as cool as possible. You stop smoking, you stop, anything that's going to cause trauma to the testicle. And so it's very difficult to say any one particular vitamin or supplement makes a difference. For me, it's always all about heat. So I really want to try and keep men's testicles cooler. So looser shorts when you're at home, just shorts and boxers. Try and minimize kind of anything tight. Exercise is good. Exercise is really good. It's good for your mental health. It's vital for life. But I don't like cycling, particularly the cycling on the weekend, Lycra, a seat pushed into your perineum for an hour. It just makes things a bit too hot. So I normally say, look, if you can try and change to running or swimming or something which is potentially causing less of a temperature. When it comes to alcohol, women have more of a negative effect than men. So men can normally get away with having 5 or 6 units a week, but the British, we like to have 5 or 6 units on a Friday night. Binge drinking like that is not appropriate. Remember, 1 pint is 2 units. So actually, if you wanted to spread out 5 or 6 units over the course of a week, 2 or 3 beers, then fine. You need to think about the fact that it takes 3 months to make a sperm. And I think a really nice way of thinking about it and getting your head around it is, in the run-up to the operation, think of yourself as pregnant for 3 months. So what will your partner do when she's pregnant for 3 months? You're going to do the same. Healthy-wise, not smoking, minimizing booze, trying to eat well. Think of yourself as pregnant for 3 months.
I love that. And now, one thing that I remember you saying, actually, asking the question on our first appointment is do I take protein shakes? And I did, and I fully admitted then and in hindsight now that it was probably just because of good marketing. I'm not that big a gym person, but for anyone who might be watching this that does have that, what was the basis of that question?
So protein supplements make me really nervous because if you think of a medicine such as paracetamol or penicillin, those drugs are very carefully monitored. The testing that goes into them, the minutiae is huge. Protein supplements, vitamins, all of these things, that they don't have that level of testing. And so we don't know what is going into those. They did a study a few years ago and they looked at protein shakes, and actually between 10 and 12% of them had extra testosterone put in them. if you take exogenous testosterone, your sperm count will deteriorate. So I don't know what's in them. You don't know what's in them. And actually, most of the protein ingredients, if you read the ingredient pack, you'll see things like emulsifiers, and it's all this processed rubbish which we want to try and get away from. One of those scoops of protein is normally about 30 grams. It's the same as a chicken breast, a boiled egg. You know what that protein is. So just change your diet to get your protein in. Step away from anything that you don't know that has been tested carefully. You're being so careful about every other bit of your life. And most people who are taking protein supplements are doing it because you want to be fit and you want to be healthy, but we have no idea what's in them. So I don't like them. And I see big improvements in men's sperm count when they stop them. Not always, but when you do see sort of significant changes, you do just think, oh my God, what is in these things?
Wow, that's incredible.
Have a chicken breast or an egg.
That's exactly what 2017 you said that to me. I remember it because I haven't had one since, because like I said, I like to keep fit, but you're doing it almost because it's just drilled into you. And yeah, that's exactly what you said, and it's so true. And you can then know if you're going down Whole Foods route, you just can't go wrong. Like organic, and that's all the things you need to be looking at to optimize your fertility. Like you said, you want the perfect patient there, and don't leave anything to chance. Don't leave any unanswered questions. Had another question just come in. What do you think of extraction procedures? Oh no, that's the first one. It's just flipped. Is having smaller or softer testicles an indicator for azoospermia?
Having smaller testicles can indicate that there's an issue. Yes, I thought you were going to ask, does it have a bearing, an outcome on success rates? But in terms of if your testicles are smaller or have changed in size, and the change can be really significant, then that can indicate there's a problem. I always think it's, if you wanted to have a baby with your partner and you're both in your early 30s, I'm always really impressed with the men that go and get a semen analysis, just so you know what your baseline is. I know it can cause unnecessary unhappiness, because there are a lot of men with not great sperm counts who get pregnant really easily, and does it cause a whole lot of unhappiness? Maybe. But it also, if you think of the number of couples who might be trying for a year or 2 years before they get the semen analysis and then find out you're azoospermic. So I think if you're worried, then get a test, do a semen analysis, reassure yourself, or see that there's a problem and maybe you need to get some advice.
Thank you. Another one's just come in. What is the price of this intervention via private means?
So it'll be different everywhere you go and up and down the country. There is a theatre cost, there is a surgeon's cost, there is an embryologist costs. I would say roughly between, I've heard quotes as low as 5,000 and quotes up to 8,000. I have heard in the States quotes as high as 30,000, which is mad. But I think in your mind should probably be around between £5,000 and £6,000. Oh.
Yeah, thank you. And I think unless any others come in, I'll just leave this one as the last question, because I think it's a good one to cover, and one that you've already certainly touched upon earlier. But how do I mentally prepare for the Micro-TESE beforehand, especially if it's the last option?
So there are a lot of really good counsellors out there for reproductive health, and if you are going through an IVF clinic, they should be able to provide you someone. I think talking to someone else, and not just your partner, can be a really healthy thing to do, just to raise the different options, what's going to happen. Having someone to talk to is really important, and it doesn't always mean that it should be your partner, because there'll be always so much guilt on your side, guilt on their side, that maybe you're not as open as you could be. But I think speaking to someone, joining your, Sean, how many men do I point towards your Knackered Knackers group who turn around and say how amazing it is to be able to talk to other men who feel the same? It's just such an amazing thing, because you're not very good at talking as men. You are, but most men are not very good at talking. And I think having the ability to talk through, right, how am I going to feel? Am I going to be uncomfortable? And the other options, the after options, if there's no sperm, things like adoption and donor sperm, I think for a lot of men, you just can't go there until you know one way or the other. But it might be worthwhile knowing a little bit about it. I'm always quite intrigued with the couples who I meet in the beginning of the journey who will have very set views. This is what we're going to do, and this is the only thing we're going to do. And I always say, look, you've got to keep a really open mind, because what you think in A is going to be so different to B. And I meet men who we've had this, really long, sad journey together and haven't found sperm. And then I meet them later on with their children, however they've had their children, and how happy they are, how sad they are, all the emotions they've gone through. So keeping an open mind and not trying to kind of have really firm decisions on this is the only thing that we'll do. I think try and be flexible.
That's an amazing answer. Thank you. And I just want to touch on a couple of parts of it. So firstly, about talking. Yeah, I will shout from the rooftops that it really helps. It really does when you find a community of guys who just get it and understand. And you mentioned, me talking. It's not about, I say this to people as well, it's not about suddenly I'm talking about it literally every day, or on a podcast or even TV at some points. It's not about that. It's about just talking, like you said, outside of those four walls is an important one as well, because it does become an echo chamber. And when you add in stress and, like I said, trauma with that as well, it's just about finding other people who can find in a friend. If even if you can't do anything else, give them the option, give them the chance, because you never know, they might be amazing, even if they haven't been through it. Because one of my best friends was absolutely amazing when I told him, and he had absolutely no experience in it, easy fertility, so to speak. And another point you mentioned about other routes, it feels like a good point to say about what we've got coming up on Sunday. I'm hosting a men's panel of donor recipient fathers who have gone this route. It'll be myself hosting with 3 other guys who are all sperm donor recipient fathers. And one of them said something, and it's such a good quote, and I'm probably going to butcher it now. It was something along the lines of, if I knew what was on the other side, it wouldn't have made the decision beforehand so hard. And it was just, I think, for one sentence to sum it up perfectly. And if you want to hear him talk, he'll be here on Sunday, and the recording will be here for everyone to watch after if you aren't about on Sunday. But it's coming back to what you said, Pippa, it's acknowledging that the end point might not be what you first envisioned, but having an open mind, because you need to when you go into this, because there are so many unknowns. And like we've said so many times, there's so much subjectivity to this. So just go in with an open mind and take the advice of your healthcare professional, and and seek out community. So yeah. Oh, one more question's just come in. Is the Micro-TESE the final option for azoospermia? What after that if it does not work?
In terms of your own genetic fertility, yes, at this point in time it is. And I wonder whether this person is asking about stem cells. And I wonder if it's worth me just kind of having a very quick comment about stem cells. I mean, in terms of, is it the end of the fertility? No, in regards to donor sperm and adoption. But if you have a Micro-TESE done by a good urologist with a good embryologist, and you are ready for that procedure in terms of you've been optimized and they don't find sperm, I always think it's a really important part of my job to then close the door, to say, this is it now, it's time to move forward. In terms of having a redo Micro-TESE, I really don't like doing them, because again, it's just elongating your pain and your process. And so I do redo Micro-TESEs. I only do them if I know that the Micro-TESE has been done by someone who I didn't know, or if there was a problem that maybe you weren't optimized. But if I do a Micro-TESE on a man and I don't find sperm, I will not do it again, because I know I did a brilliant operation, because I'd really try hard to. I know my embryologists are the best out there, and if they don't find sperm, no one else will. So yes, from my point of view, if you've had a good Micro-TESE and there's no sperm, that's it. I want to touch very briefly on stem cells, because it's obviously something that people read about and hear about, and it sounds like it could be the most amazing thing. It is not around. It's not possible. We've not done it with humans. It's something that I work an awful lot in. So we are investigating stem cell in young children who are having cancer treatment, who are going to be infertile either as well later on. But it's research based, and we've only had success in the animal model in males. And so from my point of view, in terms of men who are trying to have children with women of a fertile age now, it is unlikely to be successful in your fertile lifetime. I might be wrong. But I think if you are grasping onto, stem cells, and I hear that they're doing this in Dubai and they're researching it here and there, it's not possible at this point to use it in men who have azoospermia at this point in our medical journeys.
Excellent. And there's one final question, which I will leave things after this, because I've already taken more of your time than I promised. But it's a great way, and this is a perfect way to end it, because if anyone else does have any other questions, this will answer that for you. How can we contact you, Pippa?
So I feel really strongly about you being able to come and see me on the NHS, because we talked about expenses and things like that. And as a man, and I want to be really clear about this. So I'm sure a lot of people have had problems with GPs and funding and pathways in terms of seeing someone. So in general, with IVF funding comes via your CCG, so where you live. So if you live in Camden and Islington, then you can get referred to UCH for your IVF. It's different for men and it's different for Micro-TESEs, because there's so few people who do Micro-TESEs. The funding comes from NHS England, doesn't come from CCG. Your GP might not know this. You need to know this. So the funding comes from the NHS England. If you have azoospermia, or if you have male infertility, you go to your GP and say, I want to see a specialist who looks after male infertility. And Sean, I'm happy to give you a list of people who I think are good up and down the country who do this. If you lived in London, to be honest, it doesn't have to be London. If you live anywhere in the UK, you can say to your GP, I would like to see Pippa Sangster at UCLH, and get a referral that way. You know what the NHS is like at the moment, so waits are a bit painful. I hate talking about private practice and coming and seeing me privately, because it just, I really want to be able to help you without you having to pay for it. But, there are obviously ways you can see me quicker privately, but please look at the NHS way and see if you can come and see me that way.
Lovely. Thank you very much. And yeah, perhaps that list would be great for people who are up and down the country and can seek out people closer to them. So it's something that we'll look into.
Do you want me to mention a couple of units now, just up and down the country, that I can think of off the top of my head? I always get in trouble because I forget someone. But obviously, I'm not going to go into Scotland or Wales just because I'll forget, so don't be cross. But if I'm thinking down the country, so Newcastle, Kevin McElney, Liverpool, Mark Lucky, Manchester, VB Modgill. Oh my God, I'm going to get in such trouble when I forget people. And then you've got further down, obviously London has UCLH, Guy's, Imperial, Whips Cross, not anymore, in fact, I don't think. And then Southampton definitely do, Portsmouth do. Did I say Kings? Oh my God, I'm going to get into trouble and forget people, and I'm going to be in so much trouble. Leicester as well. But I can get a list and I can send it to you. So these are people who are like me. This is people who have been trained to do Micro-TESE. To be honest, I've trained most of these people. So these are good people up and down the country. Your only slight issue you have is quite a few of those units. Can I talk? Am I going too long? Can I just mention that NHS funding bit again? The NHS England funding was, you can have a Micro-TESE, and there's a sentence there that says you can have a Micro-TESE as long as there is funding in place for your IVF or funding for the freezing of the sperm. And how different units get around that is a bit different. So some units will only give you a Micro-TESE if your partner has got IVF funding agreed. We don't at UCH. So it doesn't matter what's happening with your partner. So you just need to find out about those different kind of rules. But you should be able to push, and you just need to go to your GP and say, I want to see this person in this unit, please refer me.
Amazing. Thank you very much. Well, Pippa, that was absolutely incredible. It's so informative, and it's quite obvious from the amount of questions that came in that it's really going to help these guys. And the recording will be here for anyone to watch down the line as well. And yeah, just so much valuable information there. So thank you.
Pleasure. Thank you for having me, and good luck to all your men who are watching this. I'm sorry for you, and I'm really hoping that you will get the families that you want.
Oh, thank you. That's a great place to leave this on. But yeah, thanks and good luck to everyone. Bye-bye.